much of that information very helpful. Same thing that we do at the University of Pittsburgh. My topic this morning is related to trends in anesthesia that we have seen in cardiac patients. These are topics that frequently come up as we take care of patients that have cardiac disease. In Cambodia, you're starting to see more patients with cardiac disease. As you go ahead and you have advanced care, now you're seeing more and more patients. I talked to one of the cardiac anesthesiologists this morning. So you're starting to do some of these procedures. As you do some of these procedures, you'll have some of these questions in terms of how do we take care of patients that have some of these different cardiac problems. The topics that I want to go through, I want to talk a little bit about antibiotics for infective endocarditis. I'd like to talk about how do we treat patients that are having cardiac stents. Also, how to care for the patient that has a pacemaker. And then lastly, talk about the use of beta blockers in patients that are having cardiac surgery and also non-cardiac surgery. As I go through this, I like to talk about evidence, and I use the American Heart Association and the American College of Cardiology, and I use the classification scores that they have determined. And when I look at this, they have 5 different scores that they've come up with. These are recommendations by the groups that come up with these scores. So first, we have strong recommendation. Second, and it means that strong recommendation, the piece that I like to show is great benefit compared to risk. The next is moderate, some benefit compared to risk. And then as I look at other classifications, they have benefit is greater or equal to risk. And then moderate, no benefit, class 3, benefit equals risk. And then harm, risk is greater than benefit. Another way that we classify is the amount of evidence. If there's a great deal of evidence, it means that there are good randomized controlled trials with possibly meta-analysis that takes a summary of those randomized controlled trials. So level of evidence, A, high quality. B is BR, randomized. Level B and R, non-randomized, meaning not good randomized controlled trials. And then we have C, limited data. And then I always worry about level C, where it is just expert opinion. So as we look at the first topic I'd like to discuss is infective endocarditis. And going through the American Heart Association has said that, yes, we have moderate recommendations for the use of antibiotics in some patients that have had previous cardiac problems. The evidence is fairly high. And then the patients that we know that we should consider for treating and preventing infective endocarditis is patients that have cardiac valve problems. They've used prosthetic material for cardiac valve repair, unrepaired congenital heart disease, and then repair of congenital heart disease, but they still have a shunt. As I look at other suggestions, patients that have had previous infective endocarditis, also something we should consider to treat. So what procedures? What are the procedures? So these are the patients, but undergoing which procedures? Dental procedures are the procedure where we have strong recommendations. So we can say if they're going manipulation of gingival tissue, or if they're having a procedure that involves periapical tissue, they should receive antibiotics. There are no recommendations for gastrointestinal or genitourinary types of procedures. Treatments from Miller, and I didn't see so much on recommendations for treatments, but these are the antibiotics that have been recommended. The next topic is patients that have had stents placed. So it sounds like your cardiac care is getting to the point where you're doing some of these procedures. And we always come up with patient that has had stents. And what do we do for that patient? The concern, if they have had stents, they're on anticoagulants. If we do surgery, they're on anticoagulants, they bleed. If we do not continue their anticoagulants, there is the risk of clotting and having a cardiac event. The recommendation at this point is that if they have bare metal stents, they should go at least 30 days without an elective procedure. There are studies that have looked at emergency surgeries, and they found that where they go ahead and continue some of the anticoagulants, it's not quite as bad as we think in terms of bleeding. The other group of stents that we look at are drug-eluting stents. So there are stents that will go ahead and they'll release medication. And with drug-eluting stents, the recommendations have changed recently from 12 months to 6 months where they should not have an elective procedure. So I've had a patient that I took care of, and this was in Bhutan. He had had drug-eluting stents placed, and in May, came to us in June, he had bad gallbladder disease, and he wanted to have his gallbladder out. We recommended that he wait for a year before he had his gallbladder out, unless we needed to do it emergently. So those are some of the recommendations for stents. Pacemakers. Pacemakers are always something that I worry about as I'm talking to my patient and doing a pre-op assessment. The problem, I want to know what type of pacemaker they have and how can I go ahead and put the pacemaker in an asynchronous mode. I have to know a little bit about the type of pacemaker. Do my patients always know what type of pacemaker they've had? Unfortunately, no. So it creates problems for us sometimes. If we know the type of pacemaker, we have a magnet, we can place the magnet and put it in an asynchronous mode. If we can't put the pacemaker in an asynchronous mode, if we use Bovi or we use if we go ahead and use cautery, it can actually cause the pacemaker to stop functioning and the patient may not be paced, which can create problems. So we have to know the type of pacemaker and how to put the pacemaker in an asynchronous mode. Now we can ask the surgeon, could you use bipolar for coagulation, for your cautery, instead of unipolar? Do surgeons like to use bipolar? No, they do not. They prefer unipolar cautery. The other problem with unipolar cautery is it can damage the pacer, and it can also lead to a burn with the leads in the pacemaker. So we try to go with those patients that have pacemakers, we try to put it in an asynchronous mode and make sure when we use cautery that we avoid cautery close to that pacemaker in those patients. The last topic I wanted to talk about in terms of cardiac care is use of beta blockers. In the United States, when I started as an anesthetist, we would frequently use beta blockers in many of our patients. And I still like to use beta blockers on occasion. And I know somebody is talking about ERAS today, enhanced recovery after surgery. And even for ERAS, we're thinking beta blockers may be helpful in terms of treating pain. But as we've looked at beta blockers, there are some results in terms of research that make us worry if we're going to use beta blockers. So we think a little bit about using beta blockers. There's a great deal of evidence in terms of the use of beta blockers. So there's 89 randomized studies that were used in a Cochrane database review that looked at these at the use of beta blockers during that during that operative time. There's 100 or more subjects in those studies. 70% received general anesthesia, and they all received perioperative beta blockers. The system that was used is Cochrane database reviews. I don't know how many of you have used Cochrane database reviews, but if you have the ability to go in and use a Cochrane database review, I use it to help guide practice a great deal. The results with cardiac surgery, they looked at the use of beta blockers. And I've put up the relative risk and also the confidence interval that helps to determine significance with some of these different outcomes that have been looked at. So cardiac surgery patients, no clear evidence to support beta blockers in terms of mortality, acute myocardial infarction, ischemia, stroke, hypotension, bradycardia, congestive failure. So, and also on here, along with the relative risk, confidence interval, and then also we have listed some of the evidence. Now, there are some things that are beneficial in terms of cardiac patients. So when we look at this, we can say ventricular arrhythmias, it does decrease ventricular arrhythmias, supraventricular arrhythmias, and it decreases hospital stay. Evidence with the length of hospital stay is not quite so long, or quite so good. So there is some beneficial evidence in terms of using beta blockers in some of our patients that have cardiac disease. Certainly those patients that have been taking beta blockers before they come into the hospital, it's very important we continue them on their beta blockers when they're in the hospital. The group of patients that we worry about is those where we decide to start beta blockers during the perioperative time period. And with those patients, we have beta blockers, non-cardiac surgery patients, and it caused an increase in mortality. So if you look, it's significant, but just barely significant, and evidence is low, but it suggests that we have an increase in mortality. So what we have seen is we have seen a change in our use in terms of beta blockers. The other evidence or the other outcomes we've looked at, cerebrovascular events, so much stronger. So we've seen stroke increase in that group. And then also, of course, hypertension and bradycardia. But it has caused us to rethink the use of beta blockers in some of our patients during that perioperative time period. Again, the important piece is when you start. So we don't like to start during the perioperative time period, but if they come in on beta blockers, we make sure we continue them. And then lastly, are there benefits? So there are some benefits. So you have to give this a little thought in terms of when you're going to use beta blockers. But acute myocardial infarction decreased with the use of beta blockers, and it was statistically significant, MI, and supraventricular arrhythmia. So I think you have to give it some thought. And I know when I first started in anesthesia many years ago, we gave beta blockers to almost many of our patients. Now we are much more selective about the type of patients that we give beta blockers. So I hope this helps you as you continue to see increasing numbers of patients that have cardiac disease, and it gives you some of the idea of those things that we struggle with on a day-to-day basis as we work with many of these patients that we see at our hospitals in the U.S. with cardiac disease. Thank you.